Good evening all, welcome all. Today we will see another interesting electrolyte abnormality, that is hypocalcemia. In this talk we will see about what is the definition of hypocalcemia, then what are the etiologies and causative factors of hypocalcemia, what are the clinical features of hypocalcemia, and what is the management of hypocalcemia. So let's start with the definition. A serum calcium level of less than 8.5 milligram per deciliter is called as hypocalcemia. In our body, calcium is maintained in a normal range of 8.5 to 10.5 milligram per deciliter. Anything less than 8.5 is called as hypocalcemia, while as anything more than 10.5 is called as hypercalcemia. So let's see what are the etiologies. Let's see first what are the functions of calcium in our human body. So it gives strength to the skeleton. It helps in cellular signaling and hormone secretion. It maintains cardiac rhythmicity and contractility. It helps in skeletal muscle contractility, and it helps in immune function and neural signaling. Calcium in our body is maintained in the normal level by feedback mechanisms, and which help to maintain extracellular calcium concentrations within a narrow physiological range, that is between 8.5 to 10.5 milligram per deciliter. A decrease in serum calcium triggers an increase in parathyroid hormone secretion and via the calcium sensor receptor on parathyroid chip cells. Parathyroid hormone in turn increases resorption of calcium from bone and distal renal tubule reabsorption of filtered urinary calcium, and it also stimulates the renal proximal tubule 125 dihydroxy D, that is active vitamin D production. This circulating 125 dihydroxy vitamin D acts on the small intestine to increase dietary calcium absorption. Collectively, these homeostatic mechanisms defend against life-threatening hypocalcemia and serve to restore serum calcium levels to a normal range. So in this way, the calcium is maintained in our body. What are the causes of hypocalcemia? It can be divided into two, that is with low parathyroid hormone levels, hypoparathyroidism, and with high parathyroid hormone levels, that is secondary hyperparathyroidism. So what are causes of hypoparathyroidism? It can be due to parathyroid agenesis, either genetic causes or X-linked mutations or syndromic in G-George syndrome, Kearns-Sayre syndrome. Parathyroid destruction due to surgical causes, autoimmune causes, acquired autoimmune polyendocrine syndromes due to radiation, due to iron or copper overload causing hemochromatosis, transfusion dependent thalassemia, Wilson disease, infiltration by metastasis, or systemic disease like sarcoidosis, IgG4 related disease, and stroma. Reduced bioactive parathyroid hormone secretion can be due to hypomagnesemia, again due to genetic or drug-induced severe hypomagnesemia, autosomal dominant hypocalcemia due to CSR activating mutations, and familial isolated hypoparathyroidism, where there is rare PTH gene mutations. And high parathyroid hormone levels, secondary hyperparathyroidism, may be due to vitamin D deficiency or impaired 125 dihydroxy D production. It can be nutritional or renal insufficiency, excessive IV phosphate infusion, vitamin D resistant, including receptor defects, intrinsic small intestine disorders with chronic calcium malabsorption in after bariatric surgery, short bowel syndrome, celiac disease, Crohn's disease, parathyroid hormone resistance to pseudohypoparathyroidism, congenital parathyroid receptor mutation syndromes, PTH receptor blocking autoantibodies, drugs like alcohol, acute and chronic ingestion, calcium chelators with massive blood transfusion, inhibitors of bone reabsorption like bisphosphonates, denosumab, increased vitamin D catabolism, phenytoin phenobarbital, phosphate-containing enemas, excessive or with renal disease, miscellaneous causes like acute pancreatitis, acute rhabdomyolysis, hungry bone syndrome after parathyroidectomy, and metastasis with marked stimulation of bone formation, respiratory or metabolic alkalosis, refeeding syndrome, pseudohypocalcemia should be ruled out wherever there is low serum calcium with malnutrition, nephrotic syndrome, cirrhosis, and even after some MRI contrast injection. So these are all causes of hypocalcemia. So let's see what are the clinical features of hypocalcemia. It can be the clinical features can be like paresthesia of fingers, toes, and circumoral regions. There might be proximal myopathy, so there might be weakness of while standing up from sitting position. Severe hypocalcemia can present as seizures, carpopedal spasm, laryngospasm, bronchospasm, QTC prolongation, ventricular tachyarrhythmias like torsades dispointis, and sudden death. So these are two important signs of hypocalcemia. One is Chostek sign is observed when there is abnormal reaction or stimulus to facial nerve just in front of the ear, and it will cause twitching of facial muscles on the same side due to hyperexcitability of the nerve. And Trousers sign, that is when a blood pressure cuff is tied around the arm and it is inflated to pressure greater than systolic pressure and it is held for 3 minutes, there will be contraction of the hand. There will be flexion at the wrist joint and there will be metacarpophalangeal joints flex, but the fingers get extended. So there is spasm. This is called as carpal spasm. This is Trousers sign. TROU double S EAUS. Trousers sign. We have to correct the calcium in case of hypoalbuminemia, and this is the formula for correction. Corrected calcium is equal to measured calcium plus zero point 0.8 into 4 minus the serum albumin. In this way, we have to treat the pseudo hypocalcemia in cases with hypoalbuminemia. So finally, what is the management? In acute management, symptomatic patients severe hypocalcemia can be corrected by giving 10% calcium gluconate, which contains 90 milligram of elemental calcium per 10 ml, and it is given as a bolus 10 to 20 ml over 10 minutes. Severe hypocalcemia can also be treated by infusion. In the 60 ml of calcium gluconate is added to 500 ml of dextrose. So the concentration of calcium will be 1 mg per ml. And this is given at a rate of 0.5 to 2 mg per kg per hour infusion. Transfusion of massive large amount units of blood can lead to citrated blood can lead to hypocalcemia. So for every 4 units of blood transfused, 10 ml of 10% calcium gluconate has to be administered. Long-term management will be treat the underlying causes. Whatever we have seen, whatever the causes of hypocalcemia, we have to treat the cause, and we can give oral calcium in the form 1 to 3 gram per day. It can be treated if there is vitamin D deficiency with 125 dihydroxyvitamin D, which is available in as a calcitriol, oral calcitriol or oral vitamin D formulations, which can be given as 60,000 units every week or 2,000 units per day for 3 months or for regularly to correct the vitamin D deficiency, and which will correct the even calcium deficiency. Thank you.